So, and there's another controversial topic about the flow diverter, the application of flow diverter in the acute phase. So, what do you think the main concern of the application of FD in acute phase, or how to balancing the rebleeding and ischemic things?
Okay, that's a great question as well. Let's consider, so broadly speaking, when we think of like application of flow diverters in that setting, I think broadly speaking, the aneurysms fall into two different groups. There's one group where other than the flow diverter, there's really no other good option.
Yeah,
The blister.
some dissection or BBA.
Yes. So those ones, it's basically if we can close the like it's either deconstructive,
Yes.
parent artery occlusion, or flow diverter. There's no other good option. So in that setting, that's one group. The other group is the aneurysms where we can use something else to temporize the aneurysm, maybe coils or something else. Like we can do something that maybe will stage. We use the flow diverter at some later stage.
Yeah.
The question is when. So that the question, like at that time is,
The timing.
we say we put some coils in, like at what time do you add the flow diverter? Can we do that 2 weeks after the rupture, right after like when
Or
we think,
immediately.
or immediately? So we're definitely, the issue of like balancing ischemic and hemorrhagic is real. The risk is definitely higher. So let's take the group where like blister aneurysm, flow diverter only, right? We're gonna have higher risk.
Yeah.
For sure, there's going to be higher risk. The question is when, so what can minimize that risk? How do we minimize the risk? So one way to minimize the risk is to control all the other parameters and factors in the patient. If there's an EVD, for example, that needs to be placed, we place it before the treatment. If the EVD can be internalized, converted to a shunt, we do that before the treatment if we can. Right?
Try to reduce the rebleeding risk.
To try to reduce the risk of like surgical manipulation of the EVD. So that's one factor. In terms of how many, we prefer to use multiple devices in these settings, because I think use of with blister aneurysms, which are basically holes in the wall, multiple devices I think has a little bit more efficacy in reducing the risk of rebleeding. The timing, so waiting maybe a little bit. Somebody comes in with a rupture from like a dorsal wall, like one of those blister aneurysms. I think after a few days of waiting, and sometimes patients arrive to the hospital a few days after their bleed, may be associated with lower incidence of rebleeding, but we don't have data for it. There's no good data.
But in one situation, when you have to put FDs in the acute phase, when will you choose the antiplatelet therapy?
Okay, so I think if you ask 5 people, you're gonna get 10 answers.
Yes.
Everyone is different here. Everyone is different. In part, it's just, I think there are intrinsic limitations in how our bodies are.
Yeah.
Like we're trying to, it's very, very difficult balance. We want to have the cake and eat it too, right? We don't want the bleeding, we don't want the clotting. And it's very, so I don't, it's obviously very hard to achieve that. So what do we do? So our practice, when we do this, our practice is to basically give an IV load, like we use integralin. So we will give an IV 2B3A inhibitor at the time when we are ready to deploy the flow diverter. We already went up, catheterized, we have the flow diverter up in the head, we are ready to deploy. Right before deployment, we give the medication. Okay, then we deploy. Now, you can also deploy and then give after a minute, depending on where it is, but it's around that time. Before this point, we don't give anything.
The same as our hospital. We will give the medicine after the deploy of the FD.
Yes.
We even do not use heparin before the deploy.
We don't either. We do not either. Which is different, right? A lot of hospitals,
they will after after catheters in the vessel, we will give heparin immediately.
Yes.
But we will wait until the stent was deployed.
Yeah, I don't give heparin. The only time I give heparin is if we use radial approach. And it's part of the radial cocktail.
Oh, yes.
So our like 2,000, 3,000 units of heparin is part of our radial cocktail. I don't think it's important, actually. I think you can give less.
Yeah.
I don't think you have to give 2 or 3. But when the patient, when they're finished, we transition them to oral anticoagulation, dual antiplatelet.
Oh,
Dual antiplatelets, that's what we do. We use dual antiplatelets typically for
no
whatever.
brilliant terapeutic?
Yeah, like, so clopidogrel, Brilinta, depending on, we use, everyone is different here too, but because we rely very much on the P2 white valve, we rely on antiplatelet testing.
Yeah.
And so because we have kind of faith in that, we can still give clopidogrel. Like if the numbers are good, whatever that good is, like let's say like less than 100, we will stick with clopidogrel. But if it doesn't, if we don't like something, then it's going to be brilliant.
Okay. Thanks for today's interview.
Okay, thank you.